Bleeding disorder. Normal homeostasis depends on blood vessel, platelets, and clotting factors. Etiology. Causes can be vascular bleeding etiologies and non-vascular bleeding etiologies. Vascular is vasculitis, like it will have Henoch's clone purpura, scurvy, vitamin C deficiency, hereditary hemorrhagic telangiectasia, Osler-Weber-Rendu syndrome. Osler-Weber-Rendu syndrome, hereditary hemorrhagic telangiectasia. Osler-Weber-Rendu syndrome, that's the vascular causes. Non-vascular causes is thrombocytopenia and clotting factors defect. Difference between platelet disorder and coagulation disorder. What is the difference between platelet disorder and coagulation disorder? Site of bleeding for platelets is mucocutaneous, while for coagulation is deep muscle, joints, and tendons, hemarthrosis. Petechia is present in platelet disorder but absent in coagulation disorder. Ecchymosis is multiple and small in platelet disorder and single and large in coagulation disorder. Bleeding after minor trauma is present in platelet disorder but absent in coagulation disorder. Bleeding after surgery delayed is absent in platelet disorder but present in coagulation disorder. ITP. Immune thrombocytopenic purpura, pathogenesis, molecular mimicry, viral infection in 1 to 7-year-old, production of autoantibodies against GP2B 3A receptors on platelets, antibody-coated platelets enter the spleen, recognized by FC receptor on splenic macrophages, lysis of platelets, autoimmune thrombocytopenia, compensatory changes in bone marrow, increased megakaryocyte production. Compensatory changes in bone marrow, increased megakaryocyte production. Immune thrombocytopenic purpura. Immune, that is due to immunity problems. Thrombocytopenic means decreased platelets. Purpura. What happens? Molecular mimicry. Viral infection in a 1 to 7-year-old child. Production of autoantibodies against GP2B and 3A receptors on platelet. So autoantibodies against platelets, specifically GP2A and 3B receptors. Antibody coated platelets enter the spleen, then the antibodies stick to that and they enter the spleen. They are recognized by the FC receptors of splenic macrophages. So the spleen macrophages FC receptor, they recognize it. It will cause lysis of platelets and autoimmune thrombocytopenia. Compensatory changes in bone marrow, increased megakaryocytosis. Types is less than 3 months is called acute, persistent 3 to 12 months, and chronic more than 12 months. Most common 60 to 75%. Spontaneous recovery is seen. Most common is acute 60 to 75% and spontaneous recovery is seen. Clinical features of acute ITP. Immune thrombocytic purpura. Age will be 1 to 7-year-old. Viral infection 1 to 4 weeks. Sudden onset of mucocutaneous bleeds. Petechia, more common than epistaxis or oral oozing. Child appears well. Rarely there is GI bleeding, hematuria, CNS bleeds which is fatal. Lymphadenopathy and splenomegaly are not seen in acute ITP. Lymphadenopathy and splenomegaly are not seen in acute ITP. If present, evaluate for other etiologies such as leukemia. If you see lymphadenopathy and splenomegaly, then evaluate for another etiology such as leukemia. Investigations: blood count, thrombocytopenia, compensation by bone marrow, peripheral smear, and bone marrow aspiration. Blood count, you will find thrombocytopenia, that is decreased platelets. It will be compensated by the bone marrow. So if you perform a peripheral smear, you will see normal size and large with young platelets. Bone marrow aspiration, you will see increased megakaryocytes. Management supportive, majority of the cases are self-limiting. Decision is to treat is not based on the platelet counts, is based on the clinical symptoms like organ bleeds and increased number of bleeds. Treatment option, IV immunoglobulins, best method. What is the treatment option? IV immunoglobulins, best option. Decrease macrophage activity, decrease platelet destruction in spleen. Decrease macrophage activity and decrease platelet destruction in spleen. Steroids, prednisolone, increase platelet production. Steroids, you give prednisolone, increase platelet production. Platelet transfusion only used in life-threatening bleeds. In life-threatening bleeds, you use platelet transfusion. Otherwise, give steroids to increase platelet production. Note, other causes of thrombocytopenia is aplastic anemia, marrow infiltration by leukemia and storage disorders, connective tissue disorders like SLE, infections parvovirus, Epstein-Barr virus, varicella, rubella, mumps, infections by parvovirus, Epstein-Barr virus, varicella, rubella, mumps, drugs, heparin, valproate, phenytoin, NSAIDs, penicillins, and cephalosporins. Drugs like heparin, valproate, phenytoin, NSAIDs, penicillins, and cephalosporins. Inherited bleeding disorder, hemophilia. Hemophilia is an inherited bleeding disorder. What happens is there is a clotting factor 8 defect, delayed clot formation, and bleeding manifestation. Because of decreased clotting factor, there is a delayed clot formation. What are the types of hemophilia? The types of hemophilia is hemophilia A, B, and C. Hemophilia A is the most common. What is the factor deficiency? Factor number 8. What is in B? Factor number 9, and C factor number 11. So A is 8, B is 9, and C is 11. A and B are X-linked recessive. Males are affected more. A is X-linked recessive and males are affected more, and C is autosomal recessive. C is autosomal recessive. Clinical feature, hemarthrosis, bleeding into a joint. What is the clinical feature? Hemarthrosis, bleeding into a joint. Hallmark feature of hemophilia. Most common joint affected is knee more than elbow and ankle. Most common affected joint is knee more than elbow and ankle. Most common affected joint is knee. Target joint, repeated bleeding into the same joint will cause fibrosis. Restriction of joint movement, most common cause of morbidity. Restriction of joint movements, most common cause of morbidity. Classification, mild, moderate, and severe. So going to severe, clotting factor activity is less than 1%. So spontaneous bleeds is present. Features, hemarthrosis, muscle hematoma, rare bleeding in CNS, iliopsoas bleed can cause shock. Neonatal like hematoma following IM injection, circumcision, large cephal hematoma. Moderate bleeding factor activity is more like 1 to 4%. Spontaneous bleed is mostly absent, but bleeding after a trauma or surgery can happen. Mild clotting factor activity is 5 to 40%. There is no spontaneous bleeds, that is unnoticed till adolescence. Investigation, coagulation profile, increase APTT, intrinsic pathway compromised. Coagulation profile, you will find increase APTT, intrinsic pathway is compromised. Factor assay, best test. Factor assay is the best test, estimates level of clotting factors in blood. Factor assay is the best test, it estimates the level of clotting factors in blood. Management, factor replacement therapy. Dose calculation based on desired percent increase. Factor replacement therapy, dose calculation based on desired percentage increase. Hemarthrosis 40%, CNS bleed 100%. Hemarthrosis 40%, CNS bleeds 100%. Dose, percentage desired increase into body weight of the child into K, where K is a constant. For hemophilia A it's 0.5, for hemophilia B it's 1.4. So factor replacement therapy, dose calculation is based on desired percentage increase. Hemarthrosis, you need 40%. CNS bleed, you need 100%. Dose is percentage desired increase into body weight of a child into K, where K is a constant. For hemophilia A, it's 0.5, and for hemophilia B, it's 1.4. So, for example, a 10 kg child has neurological bleed, CNS bleed. So, you need 100% of increase. So, 100 into 10 of child and into 1.4 because of the him because um sorry, into 0.5 because baby has hemophilia A. So 1000 into 0.5, it's 500. So dose is 500. Other treatment option: fresh frozen plasma, cryoprecipitate, contains factor 8 and fibrinogen. Fresh frozen plasma and cryoprecipitate, contains factor 8 and fibrinogen, useful only in hemophilia A. Other treatment options are fresh frozen plasma, cryoprecipitate, contains factor 8 and fibrinogen, useful only in hemophilia A. What is used in hemophilia A? Cryoprecipitate. Complication: antibodies to clotting factor. Most serious complication of therapy is anti-formation of antibodies to clotting factor. Patients stop responding to factor replacement. Treatment: bypass agents bypass the defective clotting factors in the cascade. Bypassing agents: factor type recombinant factor 7A, activated prothrombin complexes, or factor 8 inhibitor bypass activity. FIBA: non-factor type emicizumab, monoclonal antibody to factor 8 hemophilia 8 A only. Emicizumab bypassing agents are recombinant factor 7A and activated prothrombin complexes, APCs, factor 8 inhibitor bypass activity, FIBA. Von Willebrand disease, most common inherited bleeding disorder worldwide. Most common inherited bleeding disorder worldwide is von Willebrand disease. Most common inherited bleeding disorder worldwide. Most commonly autosomal dominant inheritance. Functions of von Willebrand factor: binds to factor 8, increase factor 8 half-life, acts as a bridge between platelets and subendothelial collagen. Functions of von Willebrand factor: binds to factor 8, increase factor 8 half-life, acts as a bridge between platelets and subendothelial collagen. Types 1, 2 and 3. This is von Willebrand disease, types 1, 2, and 3. Type 1, most common 80% cases, quantitative defect, partial deficiency of von Willebrand factor. Type 1 is most common 80% cases, quantitative defect, partial deficiency of von Willebrand factor. Type 2 is qualitative defect, dysproteinemia, function of von Willebrand is abnormal, levels are normal. Type 3 is most severe, quantitative defect. Type 3 is most severe, quantitative complete absence of von Willebrand factor, resembles factor 8 deficiency, hemophilia A. Clinical feature: mucocutaneous bleeds, epistaxis, gum bleeding, menorrhagia in females, severe form resembles factor 8 deficiency, hemophilia A. Investigations: coagulation profile, increase APTT, factor 8 activity affected, von Willebrand factor antigen levels used in type 1 and type 3 von Willebrand factor. Von Willebrand factor antigen levels used in type 1 and type 3 von Willebrand disease. Von Willebrand factor multimer testing, tests protein structure and functioning. Von Willebrand factor ristocetin cofactor assay. Ristocetin induces binding of von Willebrand factor to platelets. Von Willebrand factor decrease binding of von Willebrand factor to platelets. Used in type multimer testing, and ristocetin cofactor assay is used in type 2 von Willebrand disease. So coagulation profile, you'll see increased APTT, intrinsic factor pathway affected, factor 8 activities affected. Von Willebrand antigen levels can be used in type 1 and type 3 disease. Von Willebrand multimer testing, test protein structure and functioning. Von Willebrand factor ristocetin cofactor assay, ristocetin inducing binding of von Willebrand factor to platelets. In von Willebrand disease, what's happening is that von Willebrand factor is not binding to platelets, so ristocetin will be helpful. Management: desmopressin induces release of stored von Willebrand factor from endothelial cells, useful in type 1 von Willebrand factor. Induces release of stored von Willebrand factor from endothelial cells. Desmopressin induces release of stored von Willebrand factor from endothelial cells, useful in type 1 von Willebrand disease. Von Willebrand factor containing concentrates, plasma derived and recombinant factors. Von Willebrand factor containing concentrates. They are plasma derived and recombinant, useful in type 2 and type 3 von Willebrand disease.